Hey everyone, so my presentation today is on acute pericarditis, which is one of the differential diagnoses for the thorax. So for typical epidemiological data, the mean age ranges from 41 to 60 years old. Men have a twofold incidence rate compared to women. The origin, it can either be from an infectious disease or a non-infectious cause. And then roughly about 5% of chest pain related visits to the emergency department are from acute pericarditis. So for a typical subjective, the patient's going to report with sudden sharp onset of chest pain in that precordial or retrosternal area. And that just means it's the portion of the body that's behind the heart and lower chest, and then right there behind the breastbone. The patient's also going to report with pain worsening with inspiration. Their pain that they're experiencing is positional, which means they're going to have an increase in pain while lying in supine or lying down, and then they may have a decrease in pain with sitting or leaning forward. They're also going to experience some radiating pain to the neck, left shoulder, and jaw, as you can see in this common body diagram. And then some patients also may experience having a cough, rhinorrhea, or runny nose, and then a low-grade fever or shortness of breath. So the key diagnostic feature, what you're really going to see is there's going to be electrocardiographic changes. And I'll talk a little bit more about that further on in this presentation. For a physical examination, there's going to be a pericardial friction rub. And that means with acute pericarditis, there's inflammation of the pericardium that causes the walls to rub against each other, which causes an audible friction. So during auscultation, a pericardial friction rub is most audible during inspiration or at the end of expiration, with the patient leaning forward. So with a pericardial friction rub, it roughly has 3 audible components, and that's during atrial systole, ventricular systole, or ventricular diastole. And some of you may be wondering, like, how is this different from a pleural friction rub? And this is because with a pleural friction rub, there's only 2 audible components compared to pericardial, which is 3 audible components. And then lastly, there's going to be some elevation in their cardiac biomarkers. So they're going to have an increase in the C-reactive protein, erythrocyte sedimentation rate, and then an increase in leukocytes or leukocytosis. So for a typical objective, during that pericardial friction rub, you're going to hear a scratchy and squeaky high-pitched sound during auscultation, like I said, with inspiration or the end of expiration with the patient leaning forward, or even in a left lateral decubitus position, which is just them laying on their left side. About 60% of patients will present with small pericardial effusion in their echocardiography. Some patients may also have, specifically ones with idiopathic acute pericarditis, they may have jugular venous distension, arterial hypotension, or pulsus paradoxus as well. And then lastly, like I said, with the EKG changes, what you're going to see on an EKG is a diffuse ST segment elevation. You're going to see a downward deviation of the PR segment. And then roughly in around 80% of the patients, you're going to see a downsloping TP segment. So for mechanisms of symptoms, like I talked about earlier, there's usually a non-infectious cause and an infectious cause. So for non-infectious cause, some patients may have rheumatoid arthritis, or they might have had lupus. And these things can activate the inflammatory reaction, elevating the cardiac biomarkers, which then leads to a seasonal flare-up in the pericardial layers, increasing that friction during inspiration. And for infectious causes, they may have had a bacterial infection, viral, fungal, or even a parasitic infection, which that infection has a direct spread on the pericardial tissue, elevating, and it can also cause the elevation of those cardiac biomarkers like we talked about earlier as well, which then leads to that acute inflammation in the pericardium. And then like we talked about on the common body diagram, the parietal and the fibrous pericardium, they're innervated by somatosensory branches of the phrenic nerve, which then causes that referred pain to the shoulder. So decisions for the clinical decision-making is an emergent referral. This patient has chest pain, it spreads to the shoulder, their jaw. We don't automatically know if they're having a heart attack or not. So I would definitely refer them to the emergency department. And especially I wouldn't treat them because with acute pericarditis, patients should be advised to restrict all physical activity until the resolution of their symptoms or the normalization of their C-reactive protein. And then once they're sent off, if you're interested, their treatment is usually they're on aspirin or NSAIDs. They could go through corticosteroid therapy as well to help with inflammation. And then they could even be put on colchicine, which is just an anti-inflammatory medication. So now what you're going to see is an example of a situation in which there's a need for an emergent referral.
Oh, hello, Katie. Your 12:30 o'clock patient is here. You had him about 6 months ago, holding McGroin. He was the leg transplant, but he couldn't come in anymore because he had lupus. Do you remember him?
Yeah.
Well, he's back, and he came under direct access today, and his chart, I read over it. I don't know if I'm allowed to. Chest pain. He's having some chest pain, and he's over there. He looks pretty serious. I'm not very smart. I'm not a doctor, but I don't think he should be here. But here's his chart.
Right.
He's ready to go when you are. All of his paperwork is filled out. Okay.
I'll have a look at it.
Okay.
Hi, Holden. Good to see you again.
Hey, Katie. How are you? So good to see you after my
Good.
leg transplant.
Good, good. So, wanted to get you back here pretty quickly. I saw on your chart you're having some chest pain. Tell me a little bit about what's going on.
Yeah, about 2 hours ago, my chest hurt really bad, and it hurts really bad when I breathe in. So I'm sorry, I'm just so uncomfortable. It only feels better when I lean forward and such. So it's causing me some shoulder pain too, and some pain in my neck and my jaw and my arm, this side. And I remember when I had my leg transplant, I came to you and you told me about that direct access and how it could save me money and get me better faster than going to these physicians.
Mm-hmm.
So I thought, I'm hurting. I'm gonna go see Katie.
Mm-hmm.
And you're a nice little receptionist lady up there, very cute girl. She told me that you could help me. Well, no, she didn't tell you could help me. I thought you could help me because direct access,
Right.
quick.
Yeah.
And I'm having some chest pain.
For sure. Okay, so chest pain here, referring into your arm,
Yeah.
in your chest, in your neck as well.
I got a little cough too.
A cough.
It's
okay.
really sharp in my chest, right
Yeah.
here.
You
And
know,
I don't think I'm having a heart attack because my
Right.
shoulder hurts,
right.
but I might be. But I came to you first because I thought it would save me some money.
Well, I'm glad you came to me, but I do think it's going to be pretty important that we get this checked out fully through the physician.
Okay.
If it's all right with you, I think the best course of action to take would be to call 911 right now.
Right now?
Get their opinion on it, yeah,
Okay.
and then see what they tell us to do about taking you to the emergency room or not, just to get it checked out, okay?
So you think it's that serious?
I do, yeah, I do think it's that serious. You seem
Okay.
like you're in quite a bit of pain and
So
comfort right now.
do I go right now, or what are we gonna do?
We're just
You're
gonna stay
call.
here, stay here.
Okay.
Just take some
It hurts when I'm
normal
breathing.
breaths. I know, not too deep, and then we're just gonna call 911 and
Okay.
get some information from that. Okay, so just chill, hang
Thank you
out.
so much,
We're gonna
Katie.
grab the phone, call
Okay.
them, and then get you going. All right.
Okay.